Hello, my name is Tahar Rahman, and I'm currently working as a research fellow at the Valve Research Group at Beth Israel Deaconess Medical Center in Boston, Massachusetts. As for my background, I'm a cardiologist and I did my fellowship from Shifa International Hospital in Islamabad. The main content of this talk is aimed at getting acquainted with the equipment used during transseptal puncture and getting a basic understanding of the procedural workflow of transseptal puncture from interventional cardiology standpoint. Interventional echocardiographers are now routinely guiding this very common procedural step for most left-sided structural heart disease interventions. This knowledge will help enhance your capabilities and remains vital as such. I have no disclosures related to this presentation. So this is an overview of what we are going to talk about today. In the first part, I'm going to give a brief historical perspective of transseptal catheterization, various clinical indications for transseptal catheterization, and the tools commonly employed during transseptal puncture. We'll give a little bit flavor of the routine steps of the procedure, common challenges and limitations with the conventional techniques, and some new technology that is on the horizon. Overall, we'll be discussing two common techniques for doing transseptal puncture: a mechanical puncture and a radiofrequency transseptal puncture. At the end, we will briefly discuss fluoroscopic image guidance for transseptal puncture. Intra-atrial septal anatomy, echocardiographic image guidance during transseptal puncture, and troubleshooting common challenges will be discussed in detail in other sections. Transseptal puncture has been around for more than 60 years. In 1959, after successful animal experiments, these three individuals, Dr. Ross, Dr. Andrea Merrow, and Dr. Brownwald, demonstrated that intra-atrial septum could be safely crossed from the right atrium to the left atrium through the fossa ovalis, even in patients without atrial septal defects. A lot of this work was done at NIH, and it was initially developed mainly to directly measure left cardiac pressures and went on to assume extended applications over the years. So the indications for doing transseptal puncture expanded over time. In 1970s, it became a popular technique in terms of mitral valvuloplasties, and then in 1980s, electrophysiologists took this on for ablation of left-sided accessory pathways. In early 2000, this procedure was adopted into mainstream interventional cardiology in terms of paravalvular leak closures and pulmonary vein isolation for electrophysiology. Between 2005 to 2010, we saw a rising number of transseptal punctures, mainly due to increasing number of mitral valve edge-to-edge repairs and left atrial appendage occlusion procedures. And now more recently, it is also performed as part of transcatheter mitral valve replacement procedures, which is set to define the next decade of structural heart disease interventions. This is again another graphic demonstration of the historical timeline of evolving indication for transseptal catheterization over the years. For these left-sided structural heart disease interventions, the success of the procedure is in part defined by the successful transseptal puncture. And with more sophisticated left-sided transcatheter structural heart disease interventions on the horizon, the importance of precise transseptal puncture has grown manyfold. So one may ask why an imaging expert needs to know the different tools and steps of the procedure. As a matter of fact, intra-atrial septum is a complex three-dimensional structure, and transseptal puncture is a multi-step invasive procedure. And we are limited in our ability to visualize the procedure, that is only through fluoroscopy or transesophageal echocardiography. Although the main steps of the procedure remain standard, different cardiac anatomies, institutional practices, and equipment availability can lead to significant variability among the procedures. Therefore, having knowledge in echocardiography and image acquisition is just one aspect of the procedure. But this knowledge stands insufficient if you're not able to teach each individual step of the procedure, as each step comes with its own challenges and complications. Also, having an in-depth understanding of various tools your interventionist is using can significantly help you anticipate various possible challenges that might occur. This particular knowledge can also have tremendous implications for developing efficient communication among the team members during the procedure. I want to begin with some very basic anatomy of intra-atrial septum. Making a transseptal puncture is a precise step, and therefore we need to understand the three-dimensional anatomy and the neighboring structures to the intra-atrial septum. I took this beautiful diagram from this article published in the Annals of Anatomy. The true septum is only a small part of the atrial wall, and the rest of intra-atrial septum is formed primarily by the extracardiac tissue. Our aim during the procedure is to stay within the true septum, also known as fossa ovalis, which is labeled in this diagram as true intraradial septum. The intended area of puncture is essentially a triangular area of fossa ovalis, which is the area of septum inferior to the fossa right near the orifice of the tricuspid valve. You can also notice that the fossa ovalis is a more posterior structure, as we know that the superior vena cava and inferior vena cava are posteriorly situated conduits entering into the right atrium, and the fossa is actually in close proximity to these two structures. Also, the fossa ovalis is at the junction of the mid and lower third of the right atrium, and this is really where we want to be during the procedure. This is another beautiful diagram showing the actual dissected swine heart, showing the posterior location of the fossa ovalis and the proximity to the superior vena cava and the inferior vena cava. More importantly, one should appreciate the complex orientation of the true intraradial septum in relation to the adjacent cardiac structures. The relationship of fossa ovalis cannot be defined by the simple Cartesian coordinates as interior, posterior, superior, inferior, lateral, or medial. This more complex geometry is what makes trans-septal puncture a complex procedure, and only an in-depth understanding of the procedural landmarks is vital for successful trans-septal puncture. So coming to the indications for the trans-septal puncture. Diagnostically speaking, there aren't many indications nowadays to perform trans-septal puncture. Majority of the time, it is now performed for therapeutic reasons and only as part of the interventional procedures. But there are certain indications where trans-septal puncture can be helpful from diagnostic standpoint, particularly for hemodynamic assessment when we have equivocal information through echocardiography. For example, we can use trans-septal puncture to assess transaortic gradients in patients with mechanical valves, where you can get simultaneous pressure of the aorta and the left ventricle, or in patients with pulmonary disease in whom wedge pressure measurements provide unreliable information on mean mitral gradients. Even though it is a very accurate diagnostic tool in terms of left-sided pressure measurements, being an invasive technique, one has to be extremely selective to use trans-septal puncture for diagnostic purposes. In terms of therapeutic indications for trans-septal puncture, as you can appreciate, there are numerous indications. And trans-septal puncture remains the initial step for most of the left-sided structural heart disease interventions, and some common electrophysiology procedures such as pulmonary valve isolation. Some common indications enlisted here are valvuloplasties, mitral valve edge-to-edge repair procedures, valve-in-valve therapies, mitral valve replacements, paravalvular leak, electrophysiology procedures, and left atrial appendage occlusions. In fact, the exact trajectory of your catheters and devices into the left-sided cardiac chambers is dependent on the site of the trans-septal puncture. Therefore, a successful trans-septal puncture not only provides access to the left side of the heart, but it also defines the overall success of the procedure. So now we come to the different tools that are required to perform trans-septal catheterization. The exact use and indications for using each one of these tools may be beyond the scope of this discussion, but we'll aim to get a general understanding and basic know-how of various tools that are available, and we'll definitely discuss some salient features of the more commonly used tools. So essentially, for most conventional trans-septal puncture, one needs to have a sheath and a trans-septal puncture needle. As you can see, there are numerous choices in terms of sheaths. A lot of these that you see in the panel A are electrophysiology sheaths that are used for various ablation procedures, but they are also used for trans-septal punctures. For interventional cardiology standpoint, Mullins and SL1 are more commonly utilized in trans-septal catheterization. Steerable sheaths are also used nowadays, which you can see in panel B, which is the Agilis. As for the needles, there are a couple of choices as shown in panel C and E. The most commonly used ones are the Brockenbrough needle. Then there are various choices in BRK. And lastly, there are radiofrequency needles that I'll talk about later in detail. So in terms of various trans-septal sheaths, I'll briefly go over some of the salient features of more commonly available sheaths. So the most commonly used one is the Mullins sheath. It comes in single curve type, and it typically pairs with the Brockenbrough needle. Then is the non-braided and braided SL sheaths by Abbott. Braided SL sheath is used when more torqueability, pushability, and catheter stability is required. It comes in various curves, has a soft tip for atraumatic performance, comes in multiple curve options. Generally accommodates the BRK needles, which we will discuss in next slide. Then is the Torflex Trans-Septal sheet by Baylis Medical. It is the only sheet compatible with the radiofrequency needles. It is again a braided sheet and is available in different curves. In terms of needles, you have a couple of choices. More commonly used is the Brockenbrough needle by Medtronic. Comes in single fixed curve and a single length. Then are the BRK needles by Abbott. Comes as BRK, BRK1 and BRK2. There are different curves and the selection depends on the cardiac anatomy. Lastly, you have the radiofrequency needle, the NRG by Baylis Medical, that we'll talk a little bit about later in this presentation. This is the commonly used guide wire for transseptal puncture. It is a J-tip wire for safe advancement and has a radio-peg coil for better visibility under fluoroscopy. Unfortunately, as good as we can be with the transesophageal guidance and the current technology, there are certain limitations to what we have. So one limitation is the fixed curve needles. Even though there are different curves available as discussed earlier, such as different curve options available in BRKs, but oftentimes the interventionists have to manually adjust for the curvature of these needles according to each patient's anatomy. They often adjust the curvature of transseptal puncture needles at the time of insertion, or may even have to remove the needle to reshape it. So the technology is somewhat limited in that sense. This picture here shows the primary curvature of the Brockenbrough needle, and then the secondary curvature is made by the interventionist as shown on the right panel. One other limitation is that these needles can often slip when we are trying to puncture at one particular place. As puncturing the intraradial septum by these conventional techniques involves applying mechanical force against the septum, therefore there is always a risk of needles slipping. Also because the heart is a moving structure leading to translation motion of the assembly unit. So as an imaging expert, one should always be cognizant of potential slipping of the puncture needle while making the final puncture. In this example, you can see that the needle slipped while making the transseptal puncture, and as a result, the puncture occurred a lot more anteriorly than its intended position. Incidents like these during the procedure, such as mitral clip and paravalvular leak repairs, can lead to suboptimal results and can make the subsequent procedure very challenging. Another challenge is with the septums that are really floppy. Such excessively compliant intraradial septums can undergo excessive tenting prior to getting punctured, and may require considerable force to puncture and get across into the left atrium, which can result in unpredictable needle movement post-puncture, and we can also risk perforating the left atrium and the pulmonary veins. So these are some of the common challenges with these conventional tools that we have. So this brings us to more novel techniques in terms of transseptal puncture. We'll go through these one by one and see what they have to offer. One such option is the radiofrequency puncture needles. They have been in practice for more than 10 years now. They are used when there's difficulty or anticipated hurdles crossing the septum with the conventional transseptal needles, without radiofrequency energy capabilities such as the Brockenbrough needle. In such cases, radiofrequency assistance can be used. It is essentially very similar to the BRK, only that it is connected to the radiofrequency energy. So to perform a puncture with a radiofrequency needle, we first confirm tenting of the septum at the desired location with the transseptal system dilator. Then we put electrocortic system in pure cut mode, and then 20 to 40 watts of energy is delivered by touching electrocautery pen to the needle hub for 1 second, while at the same time we are advancing the needle just out of the dilator to puncture the septum. And then the electrocautery pen is withdrawn immediately and the needle is advanced into the left atrium. This technique is also known as Bowie technique. The advantage is that there is no excessive tenting. There is less risk of slippage and therefore allows for a more targeted puncture. The tip is radiolucent, so you can directly visualize under fluoroscopy the advancement of the tip into the left atrium. This technique is particularly useful in crossing fibrotic and aneurysmal septums. Commonly used radiofrequency needle, the NRG by Baylis Medical, comes in two curvatures, C1 and C0, and comes in different lengths. It is shaped just like the conventional needle, only that you can apply radiofrequency energy to it. It has side holes to allow for fluid injection and monitoring diagnostic pressure waveforms. It has a blunt tip and therefore lesser risk of damaging any adjacent structures, and prevents coring of the septal tissue while making the transseptal puncture. So this is the comparison of transseptal puncture made through the conventional puncture needle on the left and the radiofrequency needle on the right. You can clearly appreciate the smooth advancement of the NRG into the left atrium, and no excessive movement of the needle is noted at the end of the puncture, which could potentially risk perforating the left atrium. Also, there is data that this technique is more time efficient. There is even newer technology out there. One such technology is flex point steerable transseptal needle. This allows you to manually manage the needle tip, which essentially means that you can steer the needle tip as you like, and with this tool there is no longer a need to manually bend your needles according to patient's anatomy. As you can see in this clip, there's a little knob at the very distal end that allows you to turn and deflect the needle in a single axis. So in this video, you can again see a little control knob that allows you to steer the needle tip. Other than that, the overall functionality of this needle is very similar to other needles, such as the hubs at the very tip to transduce chamber pressures and inject fluids. The good thing about these steerable needles is that you can manage the tip deflection under live fluoroscopic guidance, as you can see in this clip on your left. You can even manage the deflection of the needle while you're in actual contact with the septum, as shown in this bicaval view on your right, where the needle is being deflected more superiorly. So this new technology allows for a lot of maneuverability during the procedure. There's already some published data on these steerable transseptal needles with some promising results. In this study published in 2018, 27 patients underwent transseptal puncture using the flex point steerable transseptal needle. And all patients had successful transseptal puncture except in 2 of the patients who required a change of the technique due to obvious technical limitations. And overall, no procedural complications were noted with this new technique. This is another new technology on the horizon for transseptal puncture, called the Versa Cross platform. It is also by Baylis Medical, the same company that makes the radiofrequency needles. This platform comes with a shapeable dilator, a sheath, and an actual radiofrequency wire. This all-in-one apparatus makes the procedure much more efficient. You can choose between the J-tipped and the pigtail radiofrequency wires. The radiofrequency wires are again radiolucent, and you can easily track them on fluoroscopy as they advance. Everything else is exactly similar to the conventional equipment. We even have the hub at the distal end of the dilator to direct the apparatus in 9 o'clock, 4 o'clock, or 3 o'clock position during different steps of the procedure. So conventional transseptal puncture involves multiple different steps where you go in with your J-tip guide wire, then you put the Mullins sheet, then you exchange your wire with the needle, and then you cross the septum with the needle, and then you take the dilator in, and then you take another exchange wire and advance it into the left atrium, and then you put another sheet or the clip delivery system on top of that wire. But with the Versa Cross, we now have a lot fewer steps. So what we essentially do is we put in the J-wire or pigtail, then we put the Versa Cross sheet, then we put in the radiofrequency wire and make a radiofrequency puncture to the septum, advance the radiofrequency wire into the left atrium, over which we can advance the clip delivery system. So it is essentially 4 or 5 less steps instead of more than 12 steps with the conventional technique. So let's talk a little bit about the fluoroscopic technique. This technique for transseptal puncture is important to know. Those who have been doing transseptal punctures for a long time, when transesophageal echocardiographic technology wasn't that advanced, are actually experts in doing transseptal punctures only under fluoroscopic guidance. Even today, transesophageal echocardiography and fluoroscopic guidance are often used simultaneously to guide accurate positioning of the catheter. So it is important to have a basic understanding of the fluoroscopic anatomy with respect to achieving transseptal catheterization. One should also know the important fluoroscopic landmarks. The diagram on your right shows the landmarks in the RAO and LAO orientation. We can know RAO and LAO orientation by the position of the spine in the screen. Most interventionalists have the pigtail catheter in the aorta to get a reference where the aorta and aortic valve are, which also provides them with a reference to a more interior structure, that is the aortic root. The RAO view is generally helpful to orient your device anteriorly and posteriorly, as we'll see and discuss later, whereas in the LAO, the right atrium and the left atrium are in medial and lateral orientation with reference to the screen. Overall, using different fluoroscopic views is based on the interventionist's personal preference. Without going into detail of each procedural step, as it is beyond the scope of this discussion, I will only highlight the intracardiac steps of the procedure. When the transseptal sheath is advanced over the guide wire and parked in the superior vena cava just above the superior vena cava and right atrial junction. This step of the procedure is generally performed in AP fluoroscopic projection, as shown on the right side of the screen. In transesophageal echocardiography, bicavo window is used to confirm the position of the sheath in the superior vena cava. Once this is done, then the needle is advanced within the sheath. To understand this, we have to understand the design of the equipment. The distal end of the needle has a little pointed hub as shown in the diagram on the left side that allows the proceduralist to direct the needle to different positions without actually seeing the tip. They know the orientation of the needle just by looking at the hub. So the needle is advanced up till the tip of the sheath without actually exiting the sheath at this point. More commonly, the interventionists keep the needle hub at about 9 o'clock position. So the next step is engagement of the true interlateral septum. For this step, the entire assembly unit, that is the sheath and the transseptal needle, is retracted back from the superior vena cava as a unit. What is intended here is to bring the equipment down and engage the fossa ovalis. While doing this, the interventionist generally feels two jumps. One when the dilator tip crosses the aortic knob, and the other final jump is when the tip passes under the muscular septum in the fossa. While retracting the assembly unit, most interventionists gradually turn the knob from 9 o'clock to 4 o'clock until they feel the second jump, that is when the tip has engaged the fossa ovalis, and the proceduralist generally feels the tenting and engaging of the equipment against a pliable structure. Once the needle is engaged, you want to make sure that you are either not too anterior or too posterior. At this point, the RA view is very helpful, where you have your reference of the spine and aorta to position your equipment, and ideally, the interventionists want to be between the two structures. Too anterior can risk hitting the aorta, and too posterior can lead to going out through the posterior wall of the right atrium. So the sweet spot is generally between these two structures. Once the position is confirmed, the transseptal needle is then advanced through the sheath into the left atrium. This is done by making a puncture by applying a mechanical force to the fossa ovalis, which is the true interlateral septum. Once the needle is in the left atrium, it is vital to rotate the needle hub back to 3 o'clock position from 4 o'clock position, which is done in order to prevent causing iatrogenic injury to the posterior wall of the left atrium. One very handy way of confirming the needle tip in the left atrium can be by looking at the pressure tracings, as you can see in the figure, where the waveforms have transitioned from right atrial pressure waveform to left atrial pressure waveform. And in between, there is flattening of the waveform as you're going through the septum. This is a brief rundown of the equipment utilized during transseptal puncture and the various steps of the procedure. Thank you for listening.